You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur MD.
Hello, everyone. Welcome to another episode of Parallax. So my guest today is a colleague and an interventional cardiologist. And although we have not met in person, and I hope we change that and we get to meet in person at one of the meetings now that meetings have started again, fingers crossed. I got to know her through social media, so through Twitter, and through her recent involvement in Sky Fellows course, which is a great discourse, obviously, for not only fellows in training but also practicing interventional cardiologists, because as all of us know, our field in interventional cardiology, I would say cardiology and medicine in general, is a dynamic, evolving field, and it's important to stay up to date with the latest and the greatest. And I requested her to actually come on the show and have a conversation, and she gracefully agreed. So my guest is Dr. Nadia Sutton. Dr. Nadia Sutton is an assistant professor of medicine and an interventional cardiologist at University of Michigan. And she's here to talk to us today about not only her involvement with Sky Fellows course, but in general about navigating life's challenges whilst keeping an eye on your goals and your mission and your vision. So with that introduction, Nadia, welcome on the show, and thank you so much for doing this for us.
Great. Thank you so much for having me. It's a pleasure to join you today.
So we're going to begin, I think, the show by me requesting you to tell our listeners more about your career and your path to becoming an interventional cardiologist. You are in that small percentage of women who are in interventional cardiology, and I really feel honored and proud to just know colleagues like yourself, because you've sort of shattered that glass ceiling, as they call it, as cliched as it may sound, but it's sort of unfortunate. I really hope more women join interventional cardiology. But why don't you tell us more about your path to interventional cardiology?
Absolutely. Thank you so much. And I'm just delighted to join you today and tell you a little bit about my story. And I hope that some of the lessons that I've learned along the way will be helpful to others. So just a bit of background. I grew up in the northwest suburbs of Chicago. Come from a family where my dad is from the Middle East. He's from Bahrain, and my mom is from Minnesota. And so, I sort of grew up in a mixed cultural household, and ended up going to Loyola for undergrad, pre-med track, and studied biology, and then ended up subsequently going to Boston University to do a master's in public health with the intention eventually of going to medical school. And while I was at Boston University, I had a very fortunate sort of thing happen, which was that I was looking for a full-time research position during the day so I could support myself while I was doing my master's degree in the evening. And I landed a job working for Joe Lascalzo, who is now the chief of medicine at the Brigham Hospital, and had a really wonderful experience working in the lab. He's a physician scientist, and I think that's kind of what sort of inspired me along that path. And one of the very, very early people who I interacted with was Jane Leopold, who is an interventional cardiologist and a physician scientist, and is practicing at the Brigham right now. And in fact, I just ran into Jane at CRT a couple of weeks ago, and we were just marveling about the fact that we actually met. It's unbelievable, but 20 years ago. I was like a recent graduate from undergrad, and it was really inspiring to see her at that time. So I ended up going then to medical school back at Loyola, and then met my husband in medical school. And he was from Michigan. So that's how we ended up back in Michigan after medical school. And I did all of my postgraduate training at the University of Michigan, continued on the research path. I did a couple of years of dedicated research time in the midst of my fellowship, had a couple of kids along the way, and was fortunate to be invited to stay on as faculty after I finished my fellowship. And so that's kind of where I am today.
Yeah, that's awesome and heartening to hear your path and your story. And you mentioned, a couple of really influential names, Joel Scalzo, obviously physician, scientist extraordinaire, former editor-in-chief of Circulation, and Jane Leopold, who's on faculty at the Brigham and Women's Hospital. And really, I mean, you trained at a premier academic institution, that is the University of Michigan. So tell us about, as a woman, being in interventional cardiology, or just like to back up a little bit and say cardiology, and then thinking of family planning. How did you have those conversations with yourself? How did you have those conversations with your husband? And maybe if you could also answer you sort of had your early interactions with Joel Scalzo and Jane Leopold, so perhaps cardiology came intuitively or naturally to you while you were in medicine. But maybe if you could also share with us what led you to become a cardiologist when pursuing medicine.
Yeah, those are all great questions. So initially, I was thinking about actually going into infectious diseases because I thought that was a really fascinating field. And that's actually what my sort of concentration was when I was doing my master's in public health, was in international health. And I actually did a internship in Zambia after I finished my master's in public health before I went to medical school. But so I think I really enjoyed my experience doing cardiology research before I went to medical school, but I was sort of still thinking along the lines of infectious disease as a specialty. And, I think it was sort of during medical school and at the beginning of my residency that I really started to enjoy my cardiology rotations. And so I sought out my mentor, David Pinsky. He's my research mentor, who also happens to be my division chief, like very early on in my residency, to see if I could continue doing research, but just in cardiology. And I really liked the physiology. I liked the fact that there was a lot of research going on in the area. There seemed like there was more data, perhaps. It seemed like we had more answers for questions. We had more answers for patients, although like in hindsight, I think that was maybe a little bit short-sighted of me, because I think there's still a lot of unanswered questions in cardiology. And, I thought it was a really interesting field. I liked taking care of patients who I felt like really needed the help. And I felt like I was really making an impact. So, I think those are all of the reasons I gravitated towards cardiology. And then I remember I did my first interventional cardiology rotations, and I thought it was just so wonderful. I thought it was really cool that we could make an impact by sort of mechanical means, and that you could think on your feet and you could think quickly. And I thought very highly of my colleagues, they're now my colleagues, but at the time they were my faculty. I thought they were really smart people, and I liked the way that they thought, and they kind of worked through problems quickly. So, that's kind of how I ended up, I guess, being recruited into the interventional cardiology field. Is, I really liked it, and somewhat to my surprise, I had some technical ability. So that's how that sort of occurred. And I think I also, at the very beginning, I told the interventional faculty that, it was my intention to, continue along with science. And I didn't think, if those two weren't compatible, that I didn't think I could do interventional cardiology. And fortunately for me, I was assured that they thought that would be still, feasible to be able to do both of those paths simultaneously. So I was in an institution that would support that model. There's not that many places that can do that. So that's, I guess, the first part of your question. And then the other part, this question about family planning, I'd like to say it was thought out, but I think it just was sort of a spontaneous thing that happened. And so I had my first daughter when I was an intern. And so, I took call and all those kinds of things, and that was tough, but she came along. And then I had my second daughter when I was doing like the research part of my fellowship, the T32 training grant, which was a little bit easier because I didn't have to take call. immediately. And it was tough, especially during the interventional years, because I had like two small kids, and my husband is a physician too. So, fortunately for me, he was able to kind of manage while I was working the long fellowship hours. But it's not to say that it wasn't tough. But at the same time, I mean, I don't think it's necessarily something that should be put off if somebody, wants to have a family, because it doesn't ever get easier. There's always going to be busy. And I think we could talk about that for a long time. But yeah, I think you should just have, if you're going to have a family, you can have it whenever you feel like it, because I don't think there's any right time or good time. It just depends on the person.
Yeah, no, I couldn't agree with you more. I think it's a personal decision, and I think more important, at least that's how I think about it. I think it's more important for that person to feel ready to be a parent more than anything else. I think, because, like you rightly said, I think career, you'll have different challenges at different stages in your career. And, I think it gets busier, or at least it seems that it may get busier, because I think your responsibility keeps increasing as you navigate through early and mid-career, or, at least that's how I felt through my career.
Absolutely. And I mean, I think the other thing is that, like, I know I had my kids when I was part of a training program, and a training program with having, like, sometimes 40 residents or 30 residents, it's just actually better, honestly, equipped to be able to, you know, um, have the manpower or woman power to cover if somebody needs to be off for a few months, versus like if you're in a smaller group of 5 or 6 people, it actually is maybe a little bit more. So I think that just from a practical standpoint, it's actually you should just do it whenever it seems like it's the right time for you, because I don't think it gets any easier as time goes by for the others.
Yeah, no, I couldn't agree with you more. I mean, um, we had children when the first one was when my wife was an intern, and then the second one was when she was starting ophthalmology. So, yeah, no, I agree with you. It's, again, I think it's, you have to feel that you're ready to be a parent more than anything else. That's how, at least, I felt about it when we planned for our kids. Um, but, you mentioned about the physician scientist pathway, and you also mentioned about the institutional support for you to have a career as a physician scientist. And, I think it's, personally for me, it's important. That's how I've always strived to exist as a physician, to exist as a physician investigator, because the science component is an important one for me, at least for my identity. When you were having these conversations with your faculty or with your mentors, what exactly did you ask them? And this is for, residents or fellows in training who are tuned in and listening. How do you approach your mentors or your senior faculty with a question like this?
That is a great question. And I think this is something that isn't talked about very much, just because there's not that many people who go along the physician scientist pathway, particularly in cardiology. I mean, I think it's a little bit, it's good to be realistic, because, I mean, cardiology is a specialty which is fairly lucrative, in general. If you are planning to go down a physician scientist pathway, I think it depends on, like, sort of what your goal is. So, like, I'm on the tenure track right now, and when you're on the tenure track, there is a different set of goals for advancement within the academic ladder. There's a different salary structure. There are different expectations just in general. And so that's something that I've kind of had to learn along the way, because there are actually, at the moment, I think I'm the only tenure track interventional cardiologist at my institution. There might be one other, but there's not that many that go that route, and there is actually the salary structure in particular, it's different, and that's almost at any academic institution. So, that's something to be aware of. And it's something to have a frank conversation with your division chief about. But the advantage is that you get institutional resources for developing programs or, research programs, or, depending on what your goals are, that they'll foot part of the bill for that. And so, I know I've talked to some colleagues lately who are at other institutions, and we've kind of talked about, these ideas about research programs. And, one of the things I hear from some people is that, that they don't have that institutional support to be able to achieve the goals, that they feel like they would like to achieve or that they're capable of achieving. So that's, I guess, it's a trade-off. But yeah, I mean, I didn't have that many people to ask questions of because there weren't very many people that I knew that were tenure track in interventional cardiology. So I kind of learned a lot on my own about it. But I mean, I guess what I can say is, I think we talked about, possibly talking a little bit about goal setting. It's just sort of understanding, like, what are your goals? What are you trying to achieve? And one of the big goals that I have, which may sound kind of lofty though, is like, I would like to make, some kind of an impact scientifically. And in order to do that, I mean, you need to have resources. And so that, that was something I had to talk to my division chief about when I was entertaining the possibility of staying on as a faculty member. And, fortunately the institution was, willing to support me with that goal in mind, and have continued to support me with that. But, those are sometimes they're kind of frank conversations that you have to have. And the other thing is, sorry, I'm kind of rambling on here, but you kind of have to know what your goals are. So in order to sit down and have a conversation with somebody else and say, this is what I'm trying to achieve, can you help me? You kind of have to outline in your mind, like, what your goals are, and to be able to have that conversation.
Yes, no, I'm gonna delve a little bit more into your pathway, because that's, like my eyes lit up when I heard tenure track and interventional cardiology, because those two they don't go together for the vast majority of interventionalists that I've known or I know. So congratulations on that. But, something important that you mentioned is setting up goals and, having a vision. And that's something that I will credit my now chairman, Dr. Subha Raman, who, at the time she was recruiting me to come to IU, asked me to pen down a vision statement, which, I sort of wrote a draft and sent it to a couple of colleagues at the Cleveland Clinic to take a look before I sent it back to her. But that vision statement, included what I wanted to achieve clinically, what I wanted to achieve academically, and what I wanted to, where I saw myself in maybe 5 to 10 years as a family person. So it had 3 components to it. And I couldn't agree with you more that, like, even for me, that exercise of putting my thoughts to paper helped me crystallize what exactly I wanted, clinically, academically, and from a family perspective. But getting back to tenure track, actually, I think it's a great opportunity for me, as well as for the listeners, to sort of hear from you. What exactly does it mean to be on tenure track, and what are some of the components which are different than someone who is also a faculty member, but on a non-tenure track, or so on a clinical track?
Well, those are great questions. And I feel like I'm still, like, growing to understand what some of these differences are. And ultimately at each institution, it should be published somewhere. There's usually a document, in the faculty development office that may sort of outline at that specific institution, what are the criteria or the range and criteria that are expected for somebody to be able to go up for promotion. The other thing is I kind of came to get to know our dean for faculty affairs. And sometimes, you can get that information from your like immediate division chief, but sometimes it is also helpful to get it from somebody from like a departmental level or even higher, to just kind of get a sense for like the lay of the land, because like within a department, divisions should be roughly equal in terms of what they are asking from their faculty members. And it may vary from division to division. So kind of having the information at hand so you kind of know like is what is being asked of you similar to what is being asked in somebody, from hematology, for example, that's important knowledge for you to have. But, in terms of like my path, I mean, I'm at the University of Michigan right now, and it is fairly clearly outlined that, when you're on the tenure track, it's like a up or out situation. So like if you don't sort of reach the associate professor, potentially with tenure level by a certain time point, like you have a clock, then you either have to, potentially, shift over to a different track, or, you may end up leaving academics altogether potentially. So it is a little bit of pressure. And then, because of that, when I was first starting, and because one of the criteria for sort of moving on to the associate professor level is to have, sufficient, research grant funding and publications, that I was initially assigned a clinical, I think they called me a clinical lecturer at the very beginning for the first couple of years. And they didn't want to put me as an assistant professor on the tenure track quite yet until I had external research funding. And so it was a little bit awkward for the first couple of years. People would be like, what's a lecturer? What does that do? Or do you just lecture? And here I am, like a faculty member in interventional cardiology. But, I'm not really one to care that much about titles, so I wasn't too bothered by it, but it was a little bit confusing for others. So, I spent the first couple of years with that position. And then, once I had my external NIH funding from the National Institute on Aging, then I became an assistant professor. And, and then at this point, my goal is to obtain, additional research funding and get sufficient publications and national recognition is part of the criteria, believe it or not, to be promoted to the associate professor level. And apparently, and this is what I'm sort of learning, is that the distinction of receiving tenure is actually a separate designation from being promoted to associate professor. So those two don't necessarily have to go together, but they often do. And so, a lot of it though is this idea of being nationally recognized for your, area of expertise. And so that's something that I kind of had to grapple with a little bit because it seems a little bit archaic to me. And the idea that you're being sort of externally judged on things that I think sometimes like aren't important. So there is this idea you kind of have to buy into it to some degree, even if it's, in some ways distasteful. But yeah, that's what I've learned in a nutshell.
Yeah, no, because no, this is good information. This is important information for those who are listening, because when I was transitioning institutions and at the clinic, from case to the clinic, I was assistant professor, and then when I applied for promotion, the cycle is so long, like, and I'm talking based on my own experience going through the cycle once. And that was like, I applied January 2019 to be associate professor, and then it just goes through several committees, and by the time you actually get promoted is like a year and a half later, when you sort of all your letters have accrued and it's gone through different cycles, and then it sort of goes through different committees for approval, and then it finally gets approved. So, that was educational for me just as an experience, but it's different. So when I was talking to Dr. Raman about, tenure track versus, non-tenure track. She said that tenure track would not be feasible, for me because I do not have extramural funding. So to your point of getting external funding. And I did not know that if that is the sole arbiter or if that is the sole discriminant factor for tenure versus non-tenure track. And some of what I've garnered from your explanation is that probably is a key element.
I believe so. Although, I'm still trying to understand some of the reasons why. I mean, I do know that, and you probably are aware of this as well, that, when it comes to ranking of institutions, the NIH funding is heavily weighted. And so I do know that that is important to institutions. It's interesting though, because it's almost like you have to have a parallel set of goals. Like you have your own goals for what you would like to achieve. And then there's the institution's goals for what they expect you to achieve. And so, trying to navigate between those is in itself a different challenge.
Yeah, no, I agree with you, which actually is a great segue for the topic of discussion of the podcast. And that is, setting goals and mission, if you may, because I like to use the word mission because that's how I think about it. I think that goals are short-term and missions are for life. So your goals may change based on how quickly or how slowly you achieve them, but as long as the mission stays, then the mission is for life. And then you get thrown upon, these challenges, these waves that life comes in and throws different challenges at you all the time. As long as you have a vision and a mission, you will somehow learn how to navigate through these challenges, right? While still keeping a narrow focus on your mission. So talk to us a little bit more about that mindset. How do you develop and inculcate that mindset? And it does not come obviously it didn't come naturally to me. It's like, like how you work out in the gym. It's just like working out your mind constantly to train it to think in that fashion.
I mean, I couldn't agree more. You could have taken the words right out of my mouth. I think that, and something that you said just before we were starting our podcast, really resonates with me, which is, you were talking about the fact that you find a lot of meaning, in what you do with these podcasts and these discussions. And I think that's like probably far and away the most important thing is that like, whatever your goals are, they should be something that brings, meaning to you, that there's, something in there that you find that you're sort of giving back or is a positive, thing. And, I mean, cause ultimately, that is what's important in life. And so I think when we set our goals, and I have to say, like, this isn't something that necessarily, came to me like one day. This has been sort of an evolution. And, many people have told me along the way to set goals, as, you said that your division chief asked you to do, which is, very wise. And, many people had told me to set goals, but I didn't really think about it, from the perspective that like, it's, me sort of moving towards the goal. It seemed like somebody was like, asking me to just like, do an exercise, and so the kind of the further along I've come, I've realized that you have to have those goals because, there will be challenges, and it's, without having a goal in mind, it's very easy to get waylaid or distracted by the, minor and, relatively insignificant things that come up from day to day, and to really just keep a positive attitude. We work in a very stressful field. We have very sick patients. Sometimes the staff is, feeling stressed and, may take it out in ways that is, just demonstrating that they're under stress, or, our colleagues may be cranky. There may be institutional, things that come up that are, we feel like aren't fair. There's various things, and this happens everywhere, from talking to many people. But, having your eye on your goal will help you to navigate those things and not let them bother you. Just you kind of know, I'm not going to let this, minor thing, get in the way, and just, kind of filling your mind with like, positive messages that like you can get to that goal. I think that, like you just said, it's about like exercising your mind in a way that's positive. When somebody says, I'm going to lift, 500 pounds, they go to the gym and they make, headway every day towards, getting to that goal. And in the same way, there might be minor injuries or there may be, small things that happen, but if you can kind of keep your mind set on achieving, whatever your goals are and coming to the realization of what your goals are, that's a process in itself. And sometimes that takes a lot of courage to, sometimes even admit to others what your goals are. You may think they sound silly or you may think they're unachievable. But that's just, our minds playing tricks on us. There's, anything you want to achieve, you can achieve. It's just a matter of setting your mind to it.
Yeah, no, I couldn't agree with you more. And I think this is how I think of it, right? And I completely agree with you that we work in a very stressful field, and it's a stressful environment. We're taking care of very sick patients. They're really vulnerable when they see us, particularly in interventional cardiology, whether it's in the throes of cardiogenic shock or acute MI, or a failing valve, what have you. I sort of have started following the Stoic philosophy of life, and obviously this is based on challenges I've faced in my own life over the last, I would say, 3 to 4 years, and that is what I've learned is called Dichotomy of Control, and that is I'm only going to stress and worry about what I can control. And, what I can control is how I react to external stimulation. And what I can control is how my next step is going to be in response to that external stimulation. I cannot control what the external stimuli are or are going to be. I cannot control the circumstances that I'm going to be surrounded with. And I can't control people's opinions of me. But what I can control is my reaction or my response to each of these stimuli. And as easy as it is to say it, through own experience, I can tell you it's extremely hard to practice because, there are occasions where you may get frustrated and you get angered and you want to express your emotion in X, Y, or Z fashion, but I sort of ask myself the following 3 questions. Is it whatever the action is in response to that stimulus, or whatever my words are going to be in response to that stimulus? I ask myself, is it kind? Is it honest? And is it necessary? And if that's become my test. Is it kind? Is it honest? Is it necessary? And if the answer to any of that is no, I usually stop. It's taken me a while to get there. This was not how I was born, or this was not my status quo, but this is how I am slowly becoming. And in doing so, what I've realized is I've got across a lot of unnecessary emotion in my life, and I've become more silent, and I've become more relaxed with myself. And when that happens, you sort of try to get to the goal and to the mission with more clarity. That has been my experience. I don't know if that's been your experience, but I thought what you said resonated so much with me that I thought I'll share my sort of mantra with you.
Yeah, no, absolutely. I think that's fantastic advice for anybody who's listening. And I mean, it's definitely easier said than done to have control over your reactions. But I think that is like so critical to be able to stop and sort of take stock of a situation and not immediately react and think about like what is your goal, and how you react sometimes is what can differentiate if you do or do not reach your immediate goal, so I think that that is fantastic advice, and I couldn't agree more.
Oh, no, thank you. So can you describe, and I don't know if you can, but maybe sort of give us an anecdote on some of the and you may or may not be in a position to talk to us vividly about that, and that's totally fine. I get it, but just to sort of give us an anecdote or an example of some of the situations that you may have navigated while keeping your goals intact, not setting a compromise on your goals, and then we're gonna maybe talk about what's upcoming for you with Sky.
Sure, absolutely. I mean, I can give, like, this is actually a fairly concrete example, which is that, when I was first applying for my grant, so I first applied for a K-08. A K is a NIH training grant, which usually institutions like to see that as sort of a predecessor to our level funding from the NIH. So I applied for a K-08 from NHLBI, which is the National Heart, Lung, and Blood Institute, which is the typical institute that individuals usually apply for their cardiology related K awards from. And so I applied, and they didn't discuss my grant. And, usually with these NIH grants, it takes like 6 months to get your feedback. So similar to the tenure and promotion process. So I didn't, get discussed at all, which is like not ideal. Like I thought I would at least have had my grant discussed by the study section. So then I reapplied, and it again did not get discussed. So I called the program officer, and she basically told me that like she thought my proposal was too risky, and that maybe nothing would come of it. And so she advised that I essentially scrap the grant and go in with a completely new grant. So in the meantime, one of the things, this was my goal, was to to be a physician scientist. So I really needed to get this K award. So I, kept talking to individuals and trying to get advice from different people. And that's like a big, that's a big piece of advice in itself. It just talk to lots of people when you're trying to, figure out, the way to get to your goal. And so I ended up talking to the division chief for geriatrics and palliative medicine, because my research was aging related. And he suggested I apply for a K award from the National Institute on Aging rather than NHLBI. So I applied to that one instead. So this is my third go around. And in the meantime, I had also been applying for AHA Career Development Awards. So I applied to that one, and then I got like a decent score, but not still fundable. So then I put in a fourth K award application. And of course, now a couple of years has gone by of stressful grant writing submissions. And finally that got funded. And actually it's a great award because it's actually more funding than a typical K award, and comes with a leadership development component to it, and a conference that's dedicated to individuals who are studying aging biology. And so I was actually very grateful that in a way that I did not get that K-08 funded to begin with, because this is actually much better. And at the same time, my AHA award was funded after multiple rounds as well. And it was like in the less than first percentiles, meaning got a really good score. So I thought that process taught me a lot of grant writing skills, because I felt like, for one reason or another, I wasn't very good at grant writing to start off with. It's a little different from writing a manuscript. That's the other thing I've sort of learned along the way. But I felt like I got stronger in the process and more independent with each go around. And at the end of the day, I learned a lot of skills in the process of failing initially. So, there's been other things that have come up, but I think that to me is like a very concrete example of persistence. and sort of that stick-to-itness that help people reach goals. The other thing I would just mention, which we haven't really talked about, is setting goals that like you might think are crazy, but like, if you've got a goal, go for it. Like, even if it might sound like it's bananas to the next person, the sky is the limit. I think that a lot of times we end up boxing ourselves in with these ideas that people have told us, like that something isn't achievable or nobody's been able to do it before, but that doesn't mean that like you can't do it. I had lots of people tell me along the way that it's impossible to be a physician scientist and an interventional cardiologist. And that's just not true. I mean, it might be hard for a lot of people, but like I had a lot of basic science background, and I think it's very, very achievable. It's hard, but it's not impossible.
Yeah, no, that's terrific. And so, two themes which are extremely important in the concrete example that you shared, which I think again go back to the philosophy, the Stoic philosophy, or the spiritual philosophy. One is that it's never a rejection; it's a redirection. So kind of think of rejections as redirecting your path to something higher or something you have never thought. Like for example, you getting more funding than you thought you would ever get for a KO8, and you also getting a simultaneous AHA award to sort of supplement what you got from the NIH NHLBI path. So that was just it was redirection. It was not rejection. And then success is just that's how I think of success nowadays. Based on my own experiences, and that is just moving from one failure to the next with the same enthusiasm.
Yeah, absolutely. And I mean, the other thing is that like, you might try one path and it might not work, but like it could just be a detour. Like maybe the time wasn't then for this thing, but maybe the time is in a year or two from now, and you can always come back to it. And I mean, you had mentioned that I think you said that you changed institutions at one point. And so I think that's an interesting question, especially for people, because I know like Eric, I've been at the University of Michigan since I started, and I think it's a great institution. But I remember Eric Bates told me when I was taking my first job, he's like, this is not a decision that like commits you to this position for the rest of your life. Like, so don't make it bigger than it is. That was his advice to me. And I think that ultimately sometimes people do have to, change institutions. And, I don't know what your experience has been with that, but, sometimes like if you feel like you can't reach your goals at your specific institution, but it might happen somewhere else, I think that sometimes that happens. So I don't know if you have any thoughts on that.
Yeah, no, I couldn't agree with you more. I mean, I think it's, again, just coming back to the theme of this podcast, and that is, if your goals and your mission is clear, then how you get there may be challenging and may come with X, Y, and Z detours. And I think the training exercise, at least for me, has been to train the mind to keep thinking that this is this is just a detour in the right direction, and that's how I've processed it. That's how I think about it, and I agree with you more. I think it's just setting your goals and your mission, like that should be put on paper, and that should be clear.
The other thing that I think is pretty important is just to kind of like have continual positive reinforcement, because I think that, like I said, when we talked about the fact that we do work in, stressful environments, and it is easy to get waylaid. So I think, just substituting like any, feelings of doubt or, questions in your mind with positive thinking is like really, I think, very important. That might be, for some people, meeting with somebody who you find very inspirational, even if they're not at your institution, meeting with somebody like that, listening to books, listening to podcasts like this, podcast or others, hearing from the stories of others who have been successful. Sometimes for some people it's religion, sometimes it's having a hobby, something to kind of keep you feeling positive, I think is important. That's just been my personal experience and from talking to others. So.
Yeah, no, that's great advice. So we just a few minutes left, and I want to sort of end the podcast with your upcoming role with Sky Fellows course. So tell us a little bit about that, and maybe some of your closing remarks for the podcast and for our listenership.
Yeah, absolutely. I think that one thing I have really enjoyed working with the professional societies. I've worked with ACC, AHA, as well as Sky on various committees, and I've really enjoyed it. And I think it's for, it's to have that professional, collegial relationships, and to be able to feel like you're contributing towards something that's really positive. So, but with Sky, a couple of years ago, I was on the live case planning committee. And then this year I was on the coronary track planning committee for the Sky Scientific Sessions. And I was invited to apply to be, in the pipeline to manage the Sky Fellow Summit that happens at the Sky Scientific Sessions for the next few years. And honestly, this is like a labor of love. I feel like it's stuff that I really enjoy. And I think part of the reason I enjoy it is that I think it's really fun being able to connect the really great teachers with fellows and with, learners, even, myself as included. I usually try to pick the people that I want to learn from. I think that there's some really, outstanding teachers out there. And like I said, I guess this is a leadership position, but that's not kind of how I see it. I kind of see it as, an opportunity to connect, learners with really fantastic teachers. And it's something I'm looking forward to. But yeah, it like I said, I think it's kind of comes along with this idea that, I have my own goals. My goal was never to be like the, chair of the Sky Fellows Committee. That sort of came about in the process of me trying to achieve my other goals. But I think it's a good service to perform. And like I said, I think it's something where I'm going to learn along the way too. So
that's excellent. So no, I've had a great time having this conversation with you. Thank you so much for spending a late Monday evening with us to record this episode. Any closing remarks for Parallax, for our listeners, for fellows in training or early career cardiologists?
Oh my goodness. I think a couple things. One is listen to the other episodes. I'm actually really excited to listen to them myself and hear from some of the others and get advice from others. And the second thing is just to stay positive. Whatever it is that inspires you or makes you feel fulfilled, those are the things that you should really go after, because, that's the spice of life, is just, feeling fulfilled by whatever you're doing. And, ultimately, if you have a goal and, it's something that you aspire to achieve, then that's going to help you through the tough times. So yeah, that's my advice.
Absolutely. No, that's great advice. Thank you. Thanks again, Nadia, for doing this for us. And just before ACC, are you going to be at ACC?
I will be there. Mm-hmm.
All right. I'll see you. But so, share, and others who are listening, if you want to drop in a comment to either Nadia or myself for feedback, then do so on Twitter, or you could rate us and review us on Apple Podcasts, SoundCloud, or Spotify. Thanks again, and we'll see you shortly.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.